Hello class, this is our NUR 102 lecture covering Module A, Safety. The first topic that we will discuss under Module A is promoting asepsis and preventing infection. So the definition of infection is when microorganisms capable of producing disease invade the body. So infection is spread through these 6 different links that you see listed to your right. You have the infectious agent, the reservoir, the portal of exit, mode of transmission, the portal of entry, and then you have to have a susceptible host. So first, to begin with the infectious agent could be pathogens, and then also normal flora. Normal flora is the good bacteria that resides on our skin, and so when a person has an overgrowth of good bacteria, then that good bacteria can become pathogenic and then become harmful to that patient. And so some of the ways that we see normal flora becoming pathogenic is when maybe a person does not practice proper hygiene. That's one way that the normal flora can become pathogenic. Also, we have to discuss reservoir when we talk about the 6 links of infection. And so the reservoir is the place where the pathogen lives and where it multiplies and grows. It's that place where it's nourished. The reservoir is usually an area that has moisture. And if you're reading in your book, the reservoir also has a certain temperature. It has an ideal temperature, usually of 95 degrees Fahrenheit. So pathogens or microorganisms love a warm environment. Usually, when you do your rotations and you go to surgical units, you'll notice that they are freezing cold. This is because microorganisms tend not to grow rapidly in a cold environment. In a warm environment, 95 degrees or higher, then this is an area where pathogens can thrive. So, a reservoir may be living or non-living. So, of course, humans can serve as a reservoir of infection, but also animals if an animal bites you, or insects. We've heard of insects carrying West Nile virus. So, the reservoir may be living or it may be non-living. Food that's allowed to sit out and that grows bacteria can serve as a reservoir. Also floors. When you're reading in your book, it talks about floors being the most contaminated part in a hospital. Medical equipment. Anytime we're using equipment such as let's see, if we're using a stethoscope between different patients, we should always make sure we're using some type of disinfectant wipe on that to make sure we're properly decreasing the amount of microorganisms on that stethoscope. Also, contaminated water could serve as a reservoir for infectious agents. Also, when we talk about the spread of infection, we have a portal of exit. How is that material leaving? Okay, again, the portal of exit is how the infectious agent leaves the reservoir. So, the portal of exit may be through bodily fluids, such as a person coughing, sneezing, diarrhea, a person with a surgical wound that is seeping. Also, different tubes such as IV lines, gastrointestinal tubes, Foley catheters. All of these are portals of exits of infectious agents. And then you have the mode of transmission. How is this infectious agent moving from the reservoir to another person? And so the modes of transmission, as you see here, can be by direct contact, so you actually touching or kissing a person, or indirect contact, and it says contact with a formite. A formite is something that is non-living. A formite may be something in the person's room, such as a bedside table, a telephone, maybe the side rails of the bed. And so you see here, when we talk about mode of transmission, it contrasts droplet to airborne. And so in the book, it talks about droplet transmission versus airborne transmission. One of the best things for you to remember, or the easiest things to remember, is that a droplet is bigger than something that can remain airborne. So when we have patients in the hospital that are on droplet precautions, what we have to remember with droplet, let's say a person sneezes. When that person sneezes, you have droplets that are propelled into the air and then they fall. So let's just imagine the person coughing, droplets are propelled into the air and then they fall and they hit the floor of the bed. Airborne droplets, or airborne particles, let's say that. Once that person coughs or talks or breathes, airborne particles remain suspended in the air. And so that's a problem, because anybody that goes into the room can inhale those pathogenic airborne particles or infectious particles that that person has breathed out. And so when we have a person that's on droplet precautions, patients that have flu, this would be the type of patient that will be on droplet precautions. And so of course we wouldn't want this person to cough in our face. When it's flu season, you know, we have the different reminders telling the person to cover their cough, because this is the mode of transmission for the flu. And so we always want this person to cover their cough or cover their sneeze. But airborne is a little bit different. TB patients are patients that are on airborne precautions, and as we said, airborne droplets or airborne particles remain suspended in the air. So these patients will be housed in what we call negative pressure rooms, because we want that air to circulate back out of the hospital. We don't want to pull those airborne particles out into the hallway when we open that person's room. And so patients that are on TB and that are on airborne precautions are going to be in special pressurized rooms, so that we're not pulling those airborne particles out into the hallway and putting other patients at risk. Okay, so now we have to talk about the portal of entry. How will that susceptible host receive those pathogenic agents? And so we can receive it through the eyes, the nares of the nose, mouth, through the vagina, cuts and scrapes in the skin, also any wound or surgical sites. Also, the IV site can be a portal of entry. This is why when we have patients that have IVs, we want to make sure that we're cleaning that area on a routine basis to make sure that we're freeing it of any extra organisms, microorganisms. When we have patients that have indwelling Foley catheters, we want to make sure that we're doing site care. We're cleaning around that Foley catheter, so we're trying to clean that area of as many microorganisms as we can. And then also a bite from a vector. So a mosquito is a type of vector. It's a source. You know, we know a mosquito can carry West Nile, and so a bite from a mosquito can be a portal of entry into an unsusceptible host skin. Sorry about that. So the susceptible host. This is a person with inadequate defenses, and so a person with inadequate defenses could be the person in the hospital that is already sick. And so when we're sick, that is a strain on our immune system. And so the person that's sick and that's in the hospital, their immune system is already susceptible. And so this person would serve as a susceptible host. And so when we talk about the susceptible host, we have to look at these 4 determining factors. And so first you see that we have to talk about virulence. And so when we discuss virulence, when we talk about virulence is the power of the microorganism to produce disease. So we have to look at that. And then we have to look at the organism's ability to survive in the host environment. Now, when we talked about the portal of entry, we talked about the eyes, the nares, the mouth, the vagina. But when you're reading in your book, you'll learn that the different parts of the body have enzymes, The stomach, for example, has acid, and so our bodies are designed to try to fight off pathogens when they enter the body. But some organisms are strong enough and they're resistant and they're able to fight the natural defenses that we have inside of our bodies. Also, the number of organisms. Of course, if we have an overgrowth of organisms, then the susceptible host is probably going to become sicker at a more rapid rate. And then the host defenses. Again, if the person already has a compromised immune system, then they're going to have decreased ability to fight off new infections. And so the stages of infection, you have the incubation period, and as it says here, this is from the time of infection until manifestation of symptoms. And during this time, the person can infect others. And so this makes sense, like when we talk about diseases such as HIV. HIV can have a long incubation period, and the person, you know, at the time of infection, they may not even know that they have been infected. And so during the prodromal period, this is when the person has the appearance of vague symptoms, but not all diseases will have this stage. And so again, HIV is one of those, when the person talks about the symptoms, usually the person has cold or flu-like symptoms. Maybe they have it for 1 to 2 weeks, and so usually this is early in the period when the person has become affected with it. They'll have vague symptoms, but nothing that prompts that person to go and seek medical treatment. And so after the prodromal period is when the person actually has the signs and symptoms that an actual illness is present. And so it's not those cold symptoms. The illness is more pronounced at this point. And after that period, we have the period that's called the decline. The number of pathogens decline. And so once the body has been introduced to this infection, it mounts this process where it's trying to defend itself against the microorganisms. And we'll talk more about that, such as the increase in white blood cells, okay? And so once we have that increase and the immune system starts to fight back, well, those white blood cells are going to fight those pathogens, and then we're going to see their numbers decline. And so the period of convalescence is when we have tissue repair, any cells that were damaged. During the convalescence period is when the person returns to health. So, classification of infections. First, we have by location. And so location, the person can have a local infection, and so as it says here, it can occur in a limited region of the body, such as maybe the person is walking barefoot, they get a cut on the foot, and the foot becomes infected, and so only that foot is red and reddened, and you may see edema or swelling in that area, but that's a local infection. Then the person may have a systemic infection, and so a systemic infection is something that's spread via the blood or the lymphatic system, and it can affect many regions such as septicemia. So the book talks about bacteremia, and it also talks about septicemia. So bacteremia, a person can get bacteria in the blood by things such as picking a bump. Maybe a person has a cut and bacteria enters that cut, and so they're getting some type of bacteria in the bloodstream. Well, septicemia is that infection becoming more pronounced in the blood or the lymphatic system. Septicemia is the one, if we had to say on a scale of 1 to 10 which one is more harmful to the patient, it's going to be septicemia, because this is when you have an overgrowth of that bacteria in the person's system, and then you have that infected blood or that blood with bacteria in it going to all of the organs in that person's body. So septicemia is it's one of those things that have to be treated aggressively, because your patient can die if we don't treat septicemia. Now, with classification of infections by duration, acute is when a person has a rapid onset of short duration. So usually something that we consider to be acute is less than 6 months, whereas chronic is slow, has a slow development and a long duration. So usually when we talk about a patient having a chronic disease, they're probably going to die with that chronic disease, because most chronic diseases are over 6 months, and the person will probably not die from it, but die with it. Such as if a person has, let's say, rheumatoid arthritis. The person, that's a chronic disease, which means that the person is going to have it for a long duration of time. They won't necessarily die from it, but they die with it, if that makes sense. If not, please come to me so I can clarify. And then a latent is an infection that's present with no discernible symptoms. And so, as I said again, HIV and AIDS, usually during that prodromal period, the person may have vague symptoms and may not know that they actually have been infected with the HIV virus. So we have a clicker check here, and I'm sorry we don't have our clickers. A client with living with AIDS develops hairy oral leukoplakia, an infection caused by the Epstein-Barr virus. The leukoplakia is considered, and so you have your options here. And so the best option for this question is D. The primary infection with HIV virus causes the client to become immunocompromised, thus the development of the secondary infection. And so when you're reading in your book and it talks about primary versus secondary, this is when the person has that initial illness or sickness. Let's say that the person comes into the hospital and maybe they have, let's say the person has pneumonia, and while they're in the hospital, maybe they develop a urinary tract infection. And so the urinary tract infection is a secondary infection that may follow the primary infection. And so this information is in your book on page 413. Okay, so when we talk about healthcare related infections, an infection acquired as a result of healthcare, it costs the healthcare system $4.5 billion a year. It's the leading cause of death, and it is preventable with the use of aseptic principles and techniques. And so as you go further in your nursing career, you'll find out about different healthcare related infections. One of the biggies is urinary tract infections, and then also when we talk about wounds and bed sores that develop, it's not necessarily an infection. It can develop into an infection, but some patients develop bed sores while they're being cared for in the hospital. And with changes in Medicare has changed reimbursement on things like urinary tract infections and wounds because the person did not come to the hospital with those. So it's the thought of, I guess, Medicare, that there are things that we can do as healthcare professionals to make sure that our patients don't develop a urinary tract infection, such as making sure if the person has a Foley catheter, make sure that we're performing catheter care and perineal care on a everyday basis, making sure that we're keeping the patient clean and dry. Also, when we talk about bed sores, the development of pressure ulcers, it's the responsibility of those healthcare workers to change that person's position every 2 hours. And so when these things happen, such as the UTIs or the bed sores, then hospitals are not receiving reimbursement for those things, because these things are preventable by practicing those aseptic techniques and making sure that we change our patient's position on a regular basis. So with exogenous healthcare related infection, these are pathogens that are acquired from the healthcare environment. So things that are not clean or sterilized or decontaminated appropriately in the patient's environment. And so housekeeping should come and make rounds every day on your patient to make sure that the floors are clean, that the bathrooms are clean, because those things in that environment can put the person at risk of developing secondary infections. Also, the person may have an endogenous infection. And so with an endogenous infection, this is when the normal flora multiply and cause infection as a result of treatment. And so, again, we said the normal flora is our good bacteria. And so when we have patients that are receiving antibiotics for certain conditions, sometimes we use antibiotics that we call broad spectrum antibiotics. So when we talk about something broad, this is something that's large. It covers a large area. So with broad spectrum antibiotics want to kill everything, any possible bacteria can be. The thing about it is they're in the process of in the process of the bacteria, the antibiotic killing the bacteria, it kills too much of our good bacteria with that. And so it puts us at risk of now developing a secondary infection. So our line of defense against infection. Our primary defenses are our anatomical features, and they limit the pathogen's entry. And so those things would be intact skin, our mucous membranes, tears, the normal flora of the GI tract, the normal flora of the urinary tract. The thing about our primary defenses is that they act precisely the same way against any and all intruders. And this is word for word from your book, from a simple cold virus to a deadly fungal spore. So what that means is the skin is always going to react the same way. We have that normal flora, that good bacteria on our skin. So the skin is not going to become tougher or more resilient just because it comes into contact with a virus versus a bacteria, if that makes sense. It's always going to perform its function the same way when we talk about our primary defenses. Okay? And so again, we have intact skin is a barrier that prevents anything from getting in. The respiratory tract is also another place that we have what are called cilia that line our airways. And so the purpose of those cilia, CILIA, are to sweep and to cause those bad things that we inhale. Is to sweep and make sure we're not inhaling those things. And the way that we expel them is by coughing. So those are our primary defenses. And then we have the secondary defenses, which are activated by chemicals released by the pathogens. So you may remember some of these terms from microbiology, but we have phagocytosis. That's when we have those white blood cells or those macrophages that go in and they eat up cellular debris. We have the complement cascade. The complement cascade is its complements C1 through C9. And so what happens when the complement cascade is activated is that it results in the lysis of bacteria. So again, breaking down bacteria. Then we have the inflammatory process or inflammation. And so the way that inflammation helps us is that once this inflammatory process begins, it causes a vasodilation of our blood vessels. And so once that dilation occurs, then we have more good white blood cells that can go to that area and help to eat up that bad bacteria. Also, when those white blood cells are coming, you also have red blood cells and oxygen that are going to that area as well. So it makes sense then when we think about an area of the body, maybe where the person has a cut and it becomes red, and it may, that area may be slightly painful. That's because of this inflammatory process that's going on. And so we want that process to carry forward because we have healing going on at that point, because we have the activation again of those white blood cells, and so that area is going to be reddened. Okay, it's going to be reddened. The area may be edematous, and this person may have pain in that area. But the inflammatory process lets us know that our immune system is working. So inflammation alerts us to the alerts us that we possibly have bacteria, and so there are other things that we could possibly do. Okay, and also fever lets us know that our bodies are fighting against a possible infection. And so a fever is when we have a core in the body temperature, and so we said that maybe a normal temperature was maybe 98.7 degrees. And so if you remember early in the lecture or early in your reading when we talked about the ideal environment or temperature for microorganisms, we said that that environment was 95 degrees Celsius. That's the ideal temperature. Well, the body knows that microorganisms can't stand a hot environment. So what does the body do? The body kicks the temperature up some. So this fever is a way of the body killing those microorganisms. Okay, so the last way that we have that we'll talk about is our tertiary defenses. And so these are our longer lasting defenses when we talk about primary versus secondary. The tertiary defenses, we have humoral immunity and then we have cell-mediated immunity. So with humoral immunity, you have B cell production of antibodies in response to an antigen. And so what happens with humoral immunity, let's say I come into contact with maybe the chickenpox virus. So once the chickenpox virus enters my body, well, it starts a process. And so once that chickenpox virus enters my body, just think of it like this: the B cells take pictures of the antigen, and so that's a type of surveillance. And so what happens is the next time the person comes into contact with that virus, well, the B cells have already taken pictures of that virus and posted it all over our body. So whenever we come into contact with that virus again, now we have antibodies that recognize those pictures, and they go in and they attack the virus. So the B cells and the T cells work together when we talk about humoral immunity. Now with cell-mediated immunity, this is the T cells going straight for the attack. The T cells recognize something in the body, notice that something is foreign, and they go and they directly attack that antigen. And so this is just a little pictorial description of what I just described for you. Okay, so let's talk about factors that increase the infection risk. The developmental age, so babies and the very old are more susceptible to infection, and both of them have to do with their immune system. With babies, their immune systems aren't fully developed, and as we begin to age, we start to lose more muscle mass, more of our fat storage, and then as we age, our appetites may decrease and we take in less nutrients. Well, the purpose of nutrients are for us to, get our vitamins, our fat-soluble vitamins. Our proteins are going to be necessary for tissue repair. And so we see as we begin to age that as I said, the fat storages decrease, muscle mass decrease, and then our appetites may decrease as well. So these things put us at more or a greater risk of infection. Breaks in the skin, anytime we have a break in the skin integrity, well, that offers an opportunity for microorganisms or bacteria to enter into that break in the skin. Any illness, injury, or chronic disease puts a strain on the immune system and increases our risk of developing infection. Smoking and substance abuse can put us at risk. In the book, it talks about the effects of nicotine on the cilia of the respiratory tract. And so what nicotine do is that they paralyze the cilia. So the cilia works as like little brooms in our respiratory tract to sweep all the bad stuff out. Well, when we smoke, nicotine paralyzes the cilia and they make them ineffective. And so what that means is when we breathe in things and we inhale things, the cilia aren't working, doesn't sweep that bad stuff out, and so that puts us at risk for respiratory tract infections. Of course, multiple sex partners, and when you talk about unprotected sex, that's just going to put you at risk for sexually transmitted infections. Medications that inhibit or decrease the immune response. Certain types of chemotherapy drugs, patients that are taking drugs and treatment, as treatment for cancer, those drugs kill all good and bad cells. That's what chemotherapy does. It kills good and bad cells. So in the process of treating the person, it kills red blood cells, white blood cells, and platelets. So just the agent in themselves decreases the person's ability to fight infection. And so different nursing or medical procedures, especially when we're not practicing hand washing, when we're not maintaining sterile technique for those procedures that call for sterile technique. Those things put our patients at increased risk of developing infection. And so what are the factors that support our host defenses? Well, when we have adequate nutrition, making sure that we, take in our vitamins, eat vitamin-rich foods, proteins, again, they're necessary to help our cells to repair when they have suffered an assault. So those foods, those vegetables, those vitamins are going to help to boost our immune system and our immune function. And balanced hygiene, it says here, sufficient to decrease skin's bacterial count. And so we can't be overzealous in taking baths, because what it does is, it says here, it causes the skin to crack. And so there is no way to sterilize skin. We cannot eliminate all of the microorganisms for our skin. We cannot sterilize it. So a person that becomes overzealous, that takes too many baths, well, then it excessively dries the skin and puts the person at risk of developing infection. Rest and exercise. We need rest, because anytime we talk about stress and stressors on the body, well, that decreases our immune function. And so exercise, it helps us to breathe. It helps us to get that good cardiac blood flow. We breathe in more oxygen, and these are just things that supports us as a host. Again, reducing stress and making sure that we keep up with our immunizations. And so the way that we're going to prevent infection, we are going to implement medical asepsis. This is what we do. And so it says here, this is a state of cleanliness. It's not sterilization. It's not decontamination. This is just cleaning, y'all. And so cleanliness that decreases the potential for the spread of infection. And so we promote that through maintaining a clean contact. Maintaining a clean environment. If we go in and we see the person has a lot of dirty dishes in the room, they have trash that needs to be pulled out, as the nurse taking care of that patient, we can go ahead and pull those things out. We know that these things are breeding ground for bacteria. So if we know that the person is coughing a lot and they've been on the phone a lot, we have different sanitary wipes that we can use to wipe these things down. If we know that we're going to go in and talk to this patient and maybe we're sitting our stethoscope down on this person's bedside table, we need to make sure we clean that table when we leave, because now we've brought things, microorganisms from the outside and introducing it to this person's environment. So we want to help to maintain a clean environment. Of course, we want to always make sure we wash our hands, or we can use a hospital approved alcohol-based sanitizer, not the stuff that we get from Bath and Body Works. We want to use the hospital sanitizer. These are approved sanitizers that the hospital says that it's okay for us to use. And so we want to always wash our hands. If we can't wash hands, make sure that we're using sanitizer. Always follow any guidelines or procedures that are set forth by the Centers of Disease Control. In maintaining a clean environment, we want to always clean spills and dirty surfaces. Food sitting around, sugary drinks that are allowed to sit. This is area where bacteria are prone to grow. So we want to make sure that we clean that environment. We want to remove pathogens through chemical means. Now doing this is when we disinfect. So if you think about when you're cleaning your house, sometimes if we're just cleaning our counters, we can use just regular hot water and soap. And so this is when we're cleaning. Now when we disinfect, this is when we do a little bit more and we use a disinfectant such as your Pine Sol, some of your agents that have Clorox. Some of these are chemical means of providing disinfection. Again, we want to remove any clutter from the person's room. We want to consider supplies that are brought to the client's room as infectious. So again, y'all, we don't usually have a different stethoscope for each patient. So between patients, if you don't have the sanitary wipes, you want to get an alcohol pad and make sure that you're cleaning that before you use it on the next patient. Also, we want to consider items from the client's home as contaminated. We don't know how those things have been cleaned or properly sterilized. So anything from the patient's environment, we kind of want to move those things, maybe put them in the closet, but maybe discourage the use of their household items while they're in the hospital. Again, we want to wash our hands when we arrive in the unit. Y'all, we're bringing things from our car, from the outside doors, the inside doors. We're bringing all of those germs in with us. So we always want to wash our hands when we arrive on the unit, when we leave the unit, because we don't want to put our families at risk. So we want to wash our hands when we leave the unit. Of course, y'all, we want to wash our hands. This says before and after bathroom use. So let's clarify here. Let's say that you just left a patient's room. Maybe you're taking gloves off. You did a procedure and you're running to the restroom. At that point, you would want to wash your hands before using the restroom and then after. Usually we don't wash your hands before you use the restroom. The situation, it depends on what you were doing before you had to stop for a break. You want to wash your hands before and after client contact. Again, you're bringing things from the outside in with you when you come into contact with that client. Once you come into contact with that client, you want to wash your hands so you're not taking things from that client to the outside. And then before and after contact with the client's belongings. Again, we don't know where those things were stored in their personal environment and how those things were laundered or sterilized or cleaned. So we want to make sure that we're washing our hands before we come into contact with their personal belongings. Wash our hands before we put on gloves. We want to wash our hands after we take gloves off. Before and after touching the face. We want to wash our hands, of course, before eating and after eating. When you're eating and when we're talking, you have small particles that are leaving your mouth, and those things they're coming into contact with your hands every time you open your mouth. So we want to wash our hands after we eat. Of course, after touching a contaminated article, we want to wash our hands. And whenever we see visible dirt, we want to wash our hands. If you see visible dirt, this is not the time to use a hand-based sanitizer. You want to wash your hands whenever you have visible dirt on your hands. So our hand washing guidelines for at least 15 seconds. One rule is not a rule, but one way to remember 15 seconds is to sing Twinkle Twinkle Little Star. When you're in a surgical setting, the hand washing technique is a little bit longer. It's for 2 to 6 minutes, and it's a little more extensive than your routine regular hand washing. You want to remove your jewelry and clean underneath the fingernails, because these are two places that can harbor bacteria. You want to use a bactericidal solution, or use water if the hands are visibly soiled. Use warm water, not hot. Hot dries the skin and causes it to be more susceptible to cracking. We want to apply soap to wet hands, not dry hands. Use friction, because friction helps us to release those little microbes that have adhered to our skin. Always rinse the soap, dry the hands. Try not to touch any surface of the sink with your bare hands. So, which of the following actions violates a principle that is key to proper hand washing at the bedside? So, you see your options here. And so the best answer for that would be B. Shaking your hands will not completely remove excess moisture, and then allowing for the reacquisition of bacteria on the area. And so implementing CDC guidelines, it says here that standard precautions, and when you think of the word standard, standard means for everybody. Standard precautions, we do these things no matter what. We do these things whether the person is completely healthy or what we think is completely healthy to the person is standing at death's doorstep. We use these precautions for all of our patients. And we do this because it protects the healthcare workers from exposure. it's going to decrease the transmission of pathogens from that person to us, from that person to another patient by the means of us. And it's going to protect the clients from pathogens that are carried in, as I said, from us. Maybe we didn't do those things to properly cleanse ourselves of microorganisms. Maybe we didn't want to take the PTO day and we came in and we're a little sick. So standard precautions are going to protect the client from us as well. And so when we talk about transmission-based precautions, contact precaution is just what it sounds like. This is when microorganisms are going to be spread from that person to us by direct contact. And so the person may have a draining wound, they may have secretions. And so the precautions for the person that's on contact precautions, the person needs a private room. Whenever we're coming into close contact with this patient, we're going to always make sure that we have on a gown because, again, we have a uniform on, and the uniform may come into contact with their side rails when we're leaning over to listen to the auscultate the person's heart sounds. So we need a glove on so that we're protecting that uniform for the next patient. We're going to wear a gown. We're going to use gloves. We're going to dispose of those contaminated items in the room, not outside, in the room. And then there's going to be a double bag. We're going to double bag the linen and make sure that we mark their linen. Now, with droplet precautions, remember I said there was a difference between droplet precautions and airborne. With droplet, once the person sneezes or coughs out those droplet particles, they're suspended in the air, but then they fall. They hit the floor, they hit the bed, they hit whatever. They do not stay suspended in air. And so it makes sense then, if we have a person that's coughing and sneezing and they're on droplet precautions, we've got to protect ourselves. So we need to make sure that we have on a face mask, because we know that some of the portals of entry are our eyes, our nose, and our mouth. So you may want to wear your goggles. If you have goggles, you may want to, of course, we may want to wear a mask if we're going to be within 3 feet of that patient, because we said the droplet precautions can travel 3 feet. Now, with airborne precautions, it said these are spread via air currents. And so transmission can be made via the ventilation system, shaking a person's sheets when we're trying to get their sheets together on their bed, or sweeping. And so usually patients that are on airborne precautions, such as TB, a person with tuberculosis, they're going to be in specially pressurized rooms that circulate that air back from the hospital, not inside of the hospital, but circulates it outside of the hospital. We have specialized masks for patients that are on airborne precaution. These are specialty fit masks according to the size of your face. And so you have to be fit tested for these masks when you have patients on airborne precautions, because we have to make sure we don't have any air leaks around that mask when we're taking care of patients that's on airborne precautions. Also, what we need to remember, whenever this patient is transported out of their room, let's say this person has to go for x-ray and they can't do a bedside x-ray, we have to make sure that we put this patient on a mask, because remember, they breathing out, coughing out in the hallway. Well, then we're putting our other family members, healthcare workers, visitors at risk. Okay, the client has a draining abdominal wound that has become infected. In caring for the client, the nurse will implement, and you see your precautions here, and so she's going to implement contact precautions. So protective isolation, protective environment is going to protect the client from organisms. So usually we just worry about protecting ourselves from the client. Well, some patients that have a compromised immune system, like some of our patients that are receiving treatment for cancer, they have compromised immune systems, and so they're at a greater risk of becoming sick from us than we're at risk of becoming sick from them. So we have to protect them within this hospital environment. We have to be more meticulous with their care, because they're at risk from us because of their compromised immune systems. So these patients will also have specially ventilated rooms. We don't want any standing water in their room, because this is a breeding place for bacteria. The nurse the nurse that is assigned to this person cannot be assigned to other clients with an active infection. So what that means is that if I have a client that has pneumonia or a client that has the flu, I couldn't take care of that person and this person with this compromised immune system. Now, maybe I could take care of a patient that has a new hip replacement that's not complicated, because right now this person does not have any signs of an active infection. So I want to make sure that I'm taking care of a patient that does not have any active infections when I have a person that has a compromised immune system. We always got to use our standard precautions when we have these patients. So that's the face mask, making sure we put on the gown, because we don't want to bring anything from the outside into them. Okay, so one thing that I tell my students when we're talking about standard precautions, as I said, it's a standard. We do it for everybody, and so I'm at an advantage when my patient tells me, "Hey, I've got this disease, I've got that disease. Hey, I'm HIV positive." Okay, I'm at an advantage this time because, yeah, okay, I know to glove. I know to do these things. Well, I'm at a disadvantage when I walk in and this person looks healthy. They look like, they're the picture of health, and I don't do anything. I just assume that this person does not have an active infection. Okay, we want to treat all of our patients, no matter how they look, no matter what the condition. We want to treat all of them as potentially infectious. Do we go overboard? No, we do not. We let the situation necessitate our protective equipment. Now, if I've got a person with that's got the flu, maybe I could use a face mask. Do I necessarily have to wear shoe protectors and a gown? That's overkill. Okay, we let the situation necessitate our protective equipment. If I have a confused patient that has diarrhea and this person has feces all over the room, it makes sense that I'm going to gown at that point, because I want to protect my uniform from what's going on in that person's environment. So you let the situation necessitate, what's going on with your patient, dictate the personal protective equipment that you use. But gloves, we use gloves for all of our patients. Whenever we talk about coming into contact with mucous membranes, we put on gloves. Whenever you're going to give an injection, you need gloves. Okay, if we're going in and maybe we're just shaking a person's hand, maybe we don't need gloves. If we do that, maybe that's overkill. Okay, depends on what's going on with the patient. So again, let the condition of the patient necessitate the type of personal protective equipment that you're going to use. Let the procedure to be performed necessitate the type of personal protective equipment you use. Again, doing a head-to-toe assessment. If this is a person, maybe this person is in, let's say, the person with the hip replacement. No need for me to put on gloves, eye goggles, and a gown if this person has an uncomplicated hip surgery and they don't have an infection. Okay, so just think about that. Be logical in your thinking. Okay, and and as we always say, if you have any questions, if you're, whenever in doubt, always ask an instructor. Thank you, and that ends this lecture.